now pleased to introduce, is it Huat? Huat Lim. He's a clinical instructor and hospitalist at UCSF, and he recently completed an internal medicine residency. And while he was a resident, did some of this work that he's going to present to you today on a very interesting case report.
Thank you for the kind introduction. Thank you also to Jennifer, Lewis, Stacy for inviting me here to speak today. And thank you, Tony, for sharing a very useful review of DNA damage repair, homologous recombination deficiency, and PARP inhibition in cholangiocarcinoma. I would now like to share with all of you a patient case that relates to several of the topics that Tony just spoke about. This is a case of a patient of Dr. Katie Kelly, who is one of my mentors at UCSF. It's an interesting case because it's a case of cholangiocarcinoma in the setting of a germline BRCA1 mutation, where next-generation DNA sequencing was able to provide clarity in the face of diagnostic uncertainty and also suggest several therapeutic options. So the case of this patient begins in 2011, several years ago, when he first presented to care. He's a 58-year-old gentleman who presented with a palpable abdominal mass. He underwent a CT scan of the abdomen that showed a 13 by 12 centimeter left hepatic mass, and he then underwent an extended left hepatectomy, for which the surgical pathology showed intrahepatic cholangiocarcinoma, AJCC stage T1N0M0, with negative surgical margins and no tumor in one lymph node that was excised. He did not receive any adjuvant therapy per NCCN guidelines. And for the subsequent 3 years, he was free of disease until in 2014, on a routine surveillance CT scan, he was found to have a pancreatic body mass with a focal stricture. In the image on this slide, the white arrow highlights the stricture. He then underwent an endoscopic ultrasound with FNA biopsy. And the pathology from this biopsy showed adenocarcinoma that was histologically similar to the 2011 tumor that was diagnosed previously as cholangiocarcinoma. At this point, his case was discussed at our institutional tumor board. And despite the histologic similarities between his 2011 tumor and the 2014 pancreatic mass that was biopsied, our tumor board's final assessment was that this pancreatic tumor more likely represented a second primary malignancy. So in other words, primary pancreatic cancer instead of metastatic cholangiocarcinoma, based on the atypical pancreatic location, the presentation with a focal stricture and no other radiographic evidence of disease, and also the relatively late time course for metastasis. Based on this assessment, our patient underwent treatment with a distal pancreatectomy with splenectomy, and the pathology showed adenocarcinoma with substantially more pancreatic involvement than was initially appreciated radiographically. The final pathologic diagnosis was primary pancreatic carcinoma, stage T3N0. He had a focally positive surgical margin, though no tumor was present in 12 lymph nodes that were removed. Based upon the high risk of recurrence and the focally positive margin, he then received adjuvant treatment with gemcitabine for 6 months, followed by chemoradiation with capecitabine as a radiosensitizer. Around this time, given the multiple tumors and also the fact that our patient had a family history of maternal breast cancer, he was referred for genetic testing. And the genetic testing results showed that he harbored a germline BRCA1 splice site mutation. For the following 2 years, he was then free of disease until in 2016, a surveillance MRI of his abdomen showed a 1.5 centimeter left hepatic mass. Given his BRCA1 carrier status and his history of 2 prior tumors in the preceding 5 years, he was referred for a core needle biopsy. And the pathology from that showed poorly differentiated carcinoma that was similar, both histologically and immunohistochemically, to the prior 2 tumors, the 2011 intrahepatic cholangiocarcinoma and also the 2014 pancreatic mass that at the time our institutional tumor board felt represented primary pancreatic cancer. This next slide illustrates some of the histologic similarities across the three tumors, the 2011, 2014, and 2016 tumors. Specifically, the images here demonstrate that all three specimens contain sheets and large nests of cells with eosinophilic cytoplasm, as well as large nuclei and single prominence nucleoli. Now, at this time, again, given our patient's history of a BRCA1 carrier mutation, as well as ongoing uncertainty around whether his three tumors, which were separated in time by 5 years, were clonally related, or whether the 2014 pancreatic tumor represented a separate pancreatic primary, as our tumor board suspected. At this time, we submitted our patient's tissue for next generation DNA sequencing using the Foundation One platform and using archival tissue from all three tumors. And the Foundation One results were enlightening. This table summarizes the results. They showed that our patient's three tumors, separated in time by 5 years, harbored identical genomic abnormalities with similar allele frequencies, including not just the expected germline BRCA1 mutation, but also a somatic BRCA1 nonsense mutation, as well as a PREX2 substitution mutation, and a TP53 deletion spanning exons 8 to 11. In addition, all three specimens were found to harbor a novel YWHAZ-BRAF fusion, which I'll be talking about later, with identical breakpoints after exon 5 of YWHAZ and before exon 8 of BRAF. And all three tumors also shared similar tumor mutational burdens measured in mutations per megabase. To further answer the question of clonality, copy number analysis was performed on all three specimens. The copy number plots are shown here, and as you can see, all three tumors shared strikingly similar copy number abnormalities. What's more, the 2014 and 2016 tumors harbored copy number abnormalities not present in the original 2011 tumor, including these copy number losses in chromosomes 1q, 13p, 17p, and 18q. And the 2016 tumor shared further copy number abnormalities not present in the two earlier tumors, such as these amplifications in MYC and GNAS. So, taken together, the sum of all of these genomic profiling results, we felt unequivocally demonstrated that our patient's three tumors, separated in time by 5 years, were clonally related and represented late metachronous metastases of intrahepatic cholangiocarcinoma, rather than the 2014 pancreatic tumor representing de novo pancreatic cancer, as our institutional tumor board had initially felt. What's more, the genomic profiling results provided evidence for lineage. The fact that the 2014 and 2016 tumors harbored copy number abnormalities shown here that were not present in the 2011 tumor suggested that the 2016 liver metastasis derived from the 2014 pancreatic tumor rather than from the 2011 liver primary. This next slide is a schematic figure that shows the clonal relationship across all three tumors. As we've reviewed, all three tumors harbored identical genomic alterations in BRCA1, BRAF, PREX2, and TP53, and the 2014 and 2016 tumors harbored further private alterations not present in the 2011 tumor. The 2011 and 2014 tumors had similar tumor mutational burdens, and the 2016 tumor had an increased TMB. As a clinical update, our patient's 2016 liver metastasis was treated with microwave ablation, and he remains alive and cancer-free as of today. So having shared our patient's story, I'd now like to turn to discussing its significance. We think his case is unique for 3 reasons. The first, as we've just discussed, is that it represents an example of the ability of next-generation DNA sequencing to provide diagnostic clarity in cholangiocarcinoma, in this case, by providing clear confirmation of tumor clonality and lineage. The second reason, and this is something that Tony just touched on, is that it represents an example of BRCA-Mutant Cholangiocarcinoma. So germline BRCA mutations are known to increase the risk of developing biliary tract malignancy. One study from 2002 reported that BRCA2 carrier status conferred a relative risk of 4.97 for developing gallbladder or bile duct cancer in the future. That said, BRCA-mutant cholangiocarcinoma is a rare entity. The largest published study to date on BRCA-mutant cholangiocarcinoma was a multi-center retrospective analysis published in 2017 across 5 institutions that reported 18 cases of cholangiocarcinoma associated with either a germline or somatic BRCA1 or BRCA2 mutation. Interestingly, in this study by Dr. Golan and her colleagues, the median overall survival for the subset of 11 patients who had stage 3 or 4 cholangiocarcinoma at the time of diagnosis was 25 months, substantially longer than might be expected for an advanced biliary cancer population. Also interestingly, to our knowledge, that study reported the only other case in the literature of germline BRCA1 mutant cholangiocarcinoma, with the other case being the patient that we have just reviewed. The third reason that our patient's case is unique is that he harbors a novel YWHAZ-BRAF fusion. Now, BRAF fusions in themselves are rare events. In one retrospective study of over 20,000 solid tumors, they were reported in only 0.3% of cases. Across the entire Foundation Medicine database, they are only noted in 0.5% of pancreaticobiliary cancer cases. Our patient has a YWHAZ-BRAF fusion, which to our knowledge is novel among pancreaticobiliary cancers and has not been reported in any other case, pancreaticobiliary or otherwise, in the Foundation Medicine database. The YWHAZ-BRAF fusion protein is predicted to be in frame, to be driven by the YWHAZ promoter, and to encode a constitutively active BRAF kinase domain. And the YWHAZ gene itself encodes a regulatory protein called 1433 zeta, which is involved in multiple essential cellular pathways, and its transcript has been detected in TCGA expression data, not just for cholangiocarcinoma, but also for hepatocellular carcinoma and pancreatic adenocarcinoma as well. Having reviewed the reasons that this case is unique, I'd now like to take a few minutes to discuss the implications of our patient's molecular profiling results, specifically his BRCA deficiency and the presence of a YWHAZ-BRAF fusion for his future treatment. Now, just to review, our patient, again, had not just a germline BRCA1 mutation, but he also harbored a somatic BRCA1 nonsense mutation. Both of these BRCA1 mutations are suspected to be in trans, leading to biallelic BRCA1 inactivation. This biallelic BRCA1 inactivation suggests, as Tony just discussed, that he could potentially benefit in the future from platinum chemotherapy and PARP inhibition. Indeed, had our institutional tumor board known in 2014, when his pancreatic metastasis was diagnosed, that pancreatic tumor represented metastatic cholangiocarcinoma rather than primary pancreatic cancer as they initially assessed, then the treatment recommendation would have been gemcitabine cisplatin therapy per the ABC02 trial and NCCN guidelines. As Tony just discussed, for a number of reasons, he could also benefit from PARP inhibition in the future based upon the established results in other tumor types and also limited retrospective data from the Golan et al. Cohort of 18 cholangiocarcinoma cases in which a limited subset of 4 patients in that cohort who were treated with PARP inhibition showed improved outcomes. In addition, our patient's BRAF fusion could also represent a future therapeutic target. Now, in other cancer types, such as melanoma and pediatric low-grade astrocytoma, that can involve the BRAF pathway and can be driven by BRAF fusions, early studies of first-generation RAF kinase inhibitors, such as sorafenib, have shown interesting but inconsistent results, ranging from significant clinical response to paradoxical tumor activation, leading to tumor growth. In these other cancer types, including melanoma and pediatric astrocytoma, preclinical studies and case reports of RAF dimerization inhibitors and MEK inhibitors, which act downstream of RAF in the RAS-RAF-MEK-ERK pathway, have also shown some promise. So to summarize, our patient's molecular profiling results suggest that should he need systemic therapy in the future, there are several options that could be beneficial, including platinum chemotherapy, PARP inhibition, and drugs that act on the RAS, RAF, MEK, ERK pathway should they be further along in the development pipeline. Just to summarize then, I have shared with you a unique case of a patient of Dr. Kelly's who has cholangiocarcinoma in the setting of a germline BRCA1 mutation and in whom next-generation DNA sequencing involving both copy number and fusion breakpoint analysis was able to provide diagnostic clarity by demonstrating that our patient's 3 metastases separated in time by 5 years represented late metachronous metastases of intrahepatic cholangiocarcinoma, rather than the 2014 pancreatic tumor representing de novo pancreatic cancer as initially suspected by our institutional tumor board. We also reviewed that our patient's YWHAZ-BRAF Fusion is novel among pancreatico-biliary cancers, and that his molecular profiling results suggest several systemic therapy options that could benefit him in the future. I'd like to end by thanking several people. First, Katie Kelly, one of my mentors at UCSF, John Gordon and Eric Collison in the GI Oncology Group at UCSF, Sarah Metsu, Spencer Bear, and Thomas Baton at UCSF, Megan Montijan and Phil Stevens at Foundation Medicine, and most of all, our patient who graciously agreed or permitted his story to be shared with all of you today. Thanks very much.